The acute shoulder can be a challenging area of assessment in ultrasound. Frequently, ultrasound is bypassed in favour of X-ray, CT or even MRI, but it shouldn't be. The clinical skills of a sonographer are greatly underestimated, and we can implement these skills to derive an accurate and efficient diagnosis. The most common acute presentation of shoulder pain that we encounter is that of acute calcific tendinosis, or hydroxyapatite deposition disease. Patients will present with an insidious onset of excruciating pain with globally reduced range of movement. Some clinicians will refer this query early frozen shoulder, but with this level of pain, it's calcium every time. Another common presentation is post-fall, and as we'll see, there are different types of falls. A fall off a bike or electric scooter, think fracture. And ultrasound is really good, yet underappreciated for fractures. Here is an obvious greater tuberosity fracture post-bike fall. The X-ray, however, is normal, and this is not uncommon. It's important to realize that an X-ray does not exclude a fracture. In this case, the CT confirms the ultrasound finding. In another instance, we can see a scapular fracture. As I said, there are different types of falls. If a patient presents post-fall, I'll ask if they fell with their arm outstretched or by their side. If the arm was by their side, I think AC joint injury. If outstretched with a dislocation event, I think Hill-Sachs and Bankart lesion. If no dislocation occurred, I think tendon tear. Here is a collection of shoulder dislocations, and we can see a very similar mechanism of injury. There is forced abduction, external rotation, and extension. Now, approximately 90 to 95% of shoulder dislocations are anterior dislocations, where the humerus moves anteriorly. Here, the posterior lateral humerus can contact the anterior inferior aspect of the glenoid, resulting in a Hill-Sachs defect and Bankart lesion. A Hill-Sachs defect is a posterior lateral depression fracture of the humerus. On ultrasound, we see this deep to infraspinatus, and this cortical depression differs from the synovial herniation pit we often see at this location, which we've already touched on in our anatomical concept section. When I see a Hill-Sachs, I'll drop onto the anterior inferior aspect of the glenoid to look for a bony Bankart lesion. Now, this is perhaps beyond the scope of ultrasound, but I think it's still worth knowing. The glenoid labrum is a fibrocartilaginous complex that attaches as a rim to the articular cartilage of the glenoid. If we picture a clock face, then a slap tear is a tear of the labrum between the 10 and 2 o'clock position, and a Bankart lesion is a tear in the 3 to 6 o'clock position. Now, AC joint injuries generally occur with a fall and the arm is by the side of the patient or in a football collision, as seen here. When it comes to ultrasound, often localizing the injury to the AC joint is enough, but we can add more. Commonly, the Rockwood classification is used to classify AC joint injuries. This considers soft tissue injuries to the AC joint, corticoclavicular ligaments, trapezius and deltoid muscles. Type 1 injuries are mild AC joint sprain only. Type 2 injuries where the AC ligament and joint is ruptured, with corticoclavicular ligament sprains and mild injuries to the trapezius and deltoid. Type 3 injuries is where the AC ligament, joint and the CC ligaments are ruptured with elevation of the clavicle above the acromion, with also concurrent injuries to the trapezius and deltoid. Type 4 injuries is where the clavicle is displaced posterior to the trapezius. Type 5 injuries is where the clavicle is markedly elevated more than double the normal distance to the acromion. And type 6 injuries is where the clavicle is displaced inferiorly behind the coracobrachialis and biceps tendons. So here's an example of a grade 1 AC joint injury, and this can be difficult to differentiate from normal on ultrasound findings alone. Clinical correlation is often required. Focal tenderness with painful horizontal flexion can suggest an AC joint injury. A grade 2 injury is a little more obvious. There's mild thickening and edema of the AC joint is evident. And a grade 3 injury shows some widening and elevation of the AC joint with edema and fluid. Another method to help grade and differentiate these injuries is the corticoclavicular ratio. We measure the distance between the cranial rim of the coracoid and caudal border of the clavicle and compare this to the contralateral side. Here we can correlate with published values to demonstrate a grade 3 AC joint injury, as in this case. Another common presentation, perhaps in the subacute setting, is the young, fit, athletic patient with generalized shoulder pain. And this can be due to AC joint osteolysis, essentially a stress fracture-like process to the lateral aspect of the clavicle. We see irregularity of the distal clavicle with some edema and hyperemia of the joint. This can be post-traumatic or commonly a stress-induced process. Finally, we get the patient's post-total reverse shoulder. Now, a total reverse shoulder replacement is performed on a non-repairable cuff, but if we ever ask asked to scan these patients, it will be in an acute setting. Patients will recall something tear and will present with extensive bruising as if they've ruptured their biceps or pec, but this will be a deltoid tear. Thanks for watching, guys. This concludes my shoulder series. Hopefully this will arm you with the knowledge and skills to fly the flag in the fight for relevance in musculoskeletal radiology and in the fight against convention in musculoskeletal radiology. Please like and subscribe for more.